what does a heart attack look like? Grabbing the left arm, searing, stabbing chest pain? Well, yes, but not always, especially if you're a woman. We've known for years that there are gender differences in how heart attacks present, but that didn't mean that Launceston woman Sandra Comer recognised a heart attack when it was happening to her.
The first symptom that I felt was breathlessness, because my partner and I walk every day for at least 45 minutes. And this particular day, I couldn't get around one circuit without stopping. The next day, I had a funny pain across my chest, but it was one pain in like the whole of the day. Third day, I had another set of pain go across my chest. I did go to hospital that day. They asked me lots of questions. They did a couple of tests. The doctor said, look, we can't find anything. We went home. The next day, the whole day, I felt nauseous. I was lethargic. Day 5, I got up and this pain just went from my right-hand side. It just went right across my chest and it grabbed on the left-hand side. It made me curl over a little bit and the pain was that intense. It felt like a childbirth contraction. My partner said, are you okay? And I said, no. I said, I don't think I am. Trotted off to hospital. This time they said, well, we'll put you in a bed in ER for observation. And then all of a sudden, I felt this really sharp, it was more electric pain go across my chest. And it just kept going and going, and she put an ECG on me. In the background, I heard something like code blue, and somebody says, oh, there's a heart attack going on. Oh. And I turned to my partner and I said, oh, God. I said, gosh, some poor bugger's having a heart attack. Not realising it was me. And I'm just lying there with the ECGs going and I'm moaning with pain because this is intensifying. And Greg said, yeah, he says, I don't know where, And we were going over to the resus bay and all of a sudden I've got 5 cardiologists around me. And the main guy says, you're having a heart attack, but you'll be okay. And I thought, oh. I turned to my partner and I said, it's me having the heart attack, As funny as it sounds, heart attack hadn't even entered my head. I'd had what they call a widowmaker, and everybody tells me how lucky I was to be in the emergency department when I had my heart attack. One of the cardiologists said to me, no, he said, you're not lucky. He said, you listened to your body. Your body was telling you there was something wrong and you got yourself to hospital.
That's Sandra Comer, who had a so-called widowmaker heart attack in July last year. That refers to the left main coronary artery being severely blocked. It's often fatal, which makes the rather slow reaction to Sandra's situation even scarier, especially when you realise that it's far from rare. In fact, new Australian research has shown that women get slower care than men every step of the way, even when they have the worst type of heart attack. One of the authors of this study joins us now. Welcome, Professor Zaman, who's an interventional cardiologist at Westmead Hospital and a researcher at the University of Sydney. Hi, Sarah.
Hi, Tegan. Thanks for having me.
So we've known for years that women are undertreated for heart attacks compared with men. Why is this still a problem?
Well, I think it's a pretty complex issue, and there's not one single reason that it can explain the differences that we're seeing. But I guess for myself, I've studied the delays that happen with the most severe form of heart attack. So what Sandra's describing could be a most severe form where the heart artery is actually completely blocked off. We often call it a STEMI or an ST elevation heart attack. And here we can see delays in terms of the female patient actually feels that she's low risk for the heart attack, so she takes longer to come to hospital. And then there's actually healthcare system delays as well, which is really what we were focusing in on this study.
Right, so you looked at the Victorian Cardiac Outcomes Registry and found that even from like when someone's making that call to 000 all the way through the system to when they're like on the operating table getting a stent, that there were delays between women and men.
Exactly right. And that was what was so surprising and what we actually feel like we really need to get it out there to do something about this. Because originally we knew that there were delays in female patients presenting to the hospital. But from this study, we actually looked at all the women who came in by ambulance and compared them to the men. And the delay wasn't just about the women failing to recognise their symptoms and calling the ambulance. There was actually a delay from the time where the ambulance took the call and sent out the ambulance to the patient, all the way up to getting them to the ECG, to getting them to the emergency department. And then even once they arrive in the emergency department, we're seeing a delay for that woman to get on the table where we do the stenting procedure to open up the blocked or occluded artery. And this is all adjusted for differences. So this is irrespective of differences in age or other underlying health conditions or the severity of the heart attack or the time of day that the heart attack occurred. So when we adjust for all these differences between men and women still on average take 10 to 15 minutes longer to get that blocked artery open. And it's so important because, time is muscle, is what we say as interventional cardiologists. So the longer your heart artery is blocked, the more heart muscle will die and the bigger your heart attack will be.
So 10 minutes really does make a big difference here.
And 10 minutes makes a huge difference, but keep in mind that is an average delay of 10 minutes across the spectrum. So in some women we're seeing much, much larger delays. We're talking half an hour to hours. Obviously in some women there's lesser delays, but the 10 minutes was the average delay after adjusting for all those confounders.
Right, so it feels like we've got to train everyone, women in the general public, but then also like ambulance dispatchers and paramedics and ER staff, not just cardiologists who are like the finish line here.
Exactly right, yeah. And I think as cardiologists we've started to recognise this because there's lots of publications that pretty much say the same thing, that perhaps there is a bit of a healthcare bias in recognising our female patients when they present with chest pain. But this shows that we have to educate the public, we have to educate our female patients that they can have heart attacks. We have to educate the person taking that call for the ambulance so that they know just because it's a female calling with chest pain, you don't send that ambulance out with any lower triage than if it was a man, 60-year-old man with classical symptoms. And then it goes through. We need to continually educate paramedics and healthcare providers that potentially there is some form of unconscious bias that's contributing to this delay.
Whose job is it to take responsibility for all of this education though?
Yeah, that's a really good question. In terms of the patient and the public education, we have organisations that do take it upon themselves. The National Heart Foundation, for instance, has done a fantastic job of specifically targeting campaigns for women. But the other education, it's very state-based. So, for instance, we looked at Ambulance Victoria. So it would have to be upon Ambulance Victoria then to take this study back and use it to educate their paramedics. And same with the healthcare system. It's very hard to mandate an education Australia-wide. It really has to be upon each individual institution to educate their healthcare professionals. But I guess what you could do is you could ingrain it into the medical system. So during medical school, we actually give medical students education about the potential for bias and how it can impact our patients.
So really briefly, if you had one message for Australia out of your research, what would it be?
Well, I think the main message is that there is some bias there, and I think it is upon all of us, both as if we feel that we're a patient, both as women, we need to recognise that we can have heart attacks and be aware of the presenting symptoms, and if we're a healthcare provider, that we need to be aware that there might be some unconscious bias at play, and we should look at our female patients, I guess, in the same way as we look at our male patients.
Sarah, thank you so much for joining us.
Thank you.
Professor Sarah Zaman is an academic interventional cardiologist at Westmead Hospital and the University of Sydney.